Thank you for that, Geoff. I can understand if that's very frustrating. Sorry. We'll
That's
figure
fine.
it out later. But yes. Okay, so while that poll is going, we don't have any questions in our Q&A right now, but I know I am dying to answer lots of questions or dying to ask a bunch of questions. But can we start with Lucas and Jenny? Would you like to introduce yourselves and let us know how you came to be on this panel today? Oh, Jenny, you're on mute.
Yep, I just
Thank
realized
you.
that.
Of
I can
course.
introduce myself first. So my name is Jenny. I'm somebody with lived experience of opioid use and other drugs. I used to work at Kitchener's supervised consumption site before it closed down as a peer support worker. I also worked as a peer support worker at a rapid access addiction medicine clinic, and I currently work as a harm reduction worker at an agency called Thrive HIV Prevention and Support that does services for people who live with HIV or are at risk of contracting HIV, and we also do harm reduction in that vein.
Thanks, Jenny.
And my name is Lucas. I used to be a master's student working with Jeff on research. After that, I worked at Inwell as an addiction support worker, and now I work at the same organization as Jenny as the harm reduction outreach lead for Thrive HIV here in Kitchener.
Thank you both very much. Um, can you talk a little bit about uh, the drug scene where you are, what you hear people talking about, what's in the drug supply, things like that?
I can answer that from my perspective. So the local drug supply is very toxic here. Medetomidine is in basically everything. And we've seen opioid-related paramedic calls have nearly doubled in the Waterloo region in the first half of 2026. Um, yeah, so it's quite, I would say it's in terms of as someone who's grown up and lives in Galt, it's quite visible. So seeing people on the nod is a common sight in the downtown core. But this is only a small portion of visible drug use, because as of the most updated stats, it was around nearly 30% of overdose emergency calls are in a private residence. So it's very hidden, I would say locally here in Galt and Kitchener. And speaking with participants, a lot of overdoses go unreported due to the fear of stigma of from police and first responders. So this number is expected to be much higher.
Thanks, Lucas. Jenny, did you want to say anything about what you're
Uh,
seeing, or maybe how things have changed
yeah.
over the years in terms of what the drug supply is and how people are experiencing the current drug supply?
So Luke just summed it up actually very well. So like you said, it's pretty visible. I mean, it's not like a Toronto or Vancouver open air scene, but it's definitely visible, especially in the downtown core and pockets of places where the shelters are. Um, and then there is a hidden aspect, like Lucas said, about in private residences. It appears that specifically opioid use has increased over the last 10 years. Um, and yeah, our supply is very toxic. We've got medetomidine, xylazine, we've got benzos in our drugs. So it's unpredictable. Um, yeah.
Um, I've been was thinking a lot about messaging that we have these days around drugs, the drug supply, and how that connects to these ideas around pleasure, and then also how stigma plays a role in what we think about when we think about drug use. Um, so, if we were to think about pleasure instead of risk, what do you think would be different about the way that we would do public health messaging or the way that we talk to and interact with people who use drugs? Who wants to?
I'll start that. I
Yeah,
think it would
Jenny.
take some time to get people to recognize that people can use drugs for pleasure recreationally. Drug use exists on a spectrum. It's not just because you use drugs, you're automatically an addict. Um, so, but I do think if we could recognize that there is a pleasure aspect, we could eventually reduce stigma. People could be looked at, we've got people who drink alcohol or smoke pot, and that's very acceptable. Promoted, a lot of the time. So if we could do that with other drugs, by, recognizing that there is a pleasure aspect, it's not just to, reduce pain or deal with trauma. I think that would make it a little bit more humanizing and reduce stigma.
That's such a great answer. I'm thinking, because so much of what I've been thinking about is how one of our tactics to try to garner people's support for services for people who use drugs is to talk about people experiencing trauma, deprivation, pain, and things like that, as if that kind of allows people to experience drug use, makes drug use acceptable or understandable. And how does it? What do we think? Like, can there still be ways of eliciting compassion for people when they're maybe using it for pleasure? I don't know, Geoff, you've been thinking about these things. Do you have anything you want to say about that around who deserves to use substances and under what situation?
I think it's a difficult question because, ultimately, and tying back to your last question about how things might change is, I think probably services would get less funding, right? I mean, I think when we talk about harms and fixing all these harms, like that has for a funder, although, conservative governments also don't necessarily care about those things, but that's a bit more palatable than saying, oh, we have this service that we want to maximize the pleasure that people are getting from their drugs, right? So I think that would probably elicit responses like, well, why are my tax dollars going towards someone having a pleasurable experience, right? And so I think that's a difficult challenge to overcome, right? And so I when I think about this work around pleasure, obviously people are experiencing pleasure through using opioids, and so I think about it less at a societal level, even though it's kind of easy to go to that. And so I think more at a very small scale community level. So, how could this impact outreach workers' day-to-day ways of engaging with people? And part of this is I'm a bit more while I am an idealist, I'm a bit more pragmatic about what implications this has. So, I don't think it's gonna completely overhaul how everyone in the world thinks about drugs. We've been trying to change that for decades, right? And so I think, yeah, that's kind of where I go. And importantly, people who are working on in direct service roles are the ones who are going to be speaking with people who use drugs the most, right? And supporting them. And so I think it really needs to start there. But,
Thanks, Geoff. Just looking at some of the questions that we've got a bunch of questions now in the Q&A, so let's dive in there. The first question is, could we hear more about what people with lived experience feel when coming up with oxygen or rescue breathing versus naloxone alone? I'm wondering, Jenny, with your experience working in the supervised consumption services, was there a time at the supervised consumption services where you didn't have naloxone or you didn't have oxygen? Or maybe you can even talk about how that shifted before the supervised consumptions came in, when supervised consumption started, and now that the supervised consumption site is closed. What are people's experiences of naloxone versus oxygen? And what's available now. Yeah.
So coming to with oxygen is just a much gentler way to come out of the overdose. I know everybody knows this, but naloxone it reverses the effects of the opioids and it kicks the opioids off the receptors. So it's a lot more jarring, can put people into withdrawal. So we would have a lot of people who would come in and say, if I overdose, don't naloxone me. We're kind of like, well, we'll see how it goes. Oxygen was always our number one first measure, and we try not to use naloxone whenever possible, or if we did have to use it, we would titrate the dose to make it as gentle as possible coming to. So that was the experience at the CTS. But out in the community, I mean, naloxone is the main message out there. A lot of people don't even know about rescue breathing, don't know about oxygen. And I mean, we had oxygen at the supervised consumption site, but a lot of other agencies don't have it. So it's not ideal. Yeah.
I think that part's really, oh, go ahead, Geoff.
Yeah, and so I think like building on that, I think like a natural next step is, or a question is like, why don't other places have oxygen, right? Like we're, lots of discussion around supervised consumption sites closing down, and obviously it's completely devastating. But now that people are coming to or overdosing in other spaces, like should those spaces also not have this responsibility embedded within their services to also provide oxygen? And I just think, yeah, like curious about other people who are working on the front lines. Like, is the go-to is the policy in organizations to just immediately give naloxone and then do chest compressions and rescue breathing? Like, it's it's not the same everywhere, right? And so part of this would also be around developing policies that could be applied to other settings. So it's not just like, oh, well, the site doesn't exist, so we just continue on with the status quo. But no, like all the other sites are and drop-in spaces, et cetera, like could also use oxygen tanks, could also promote rescue breathing, right? And so I think these things are actually not challenging to do. But part of it is maybe just a rethink on what the current practice is.
Yeah, I'm wondering, Lucas, what do you think might be some of the barriers to that? And how could we overcome those barriers so that we could make it more accessible, oxygen or rescue breaths?
I think Narcan is the easy solution because it's very quick, it's very accessible, especially the nasal one. Now, I know that a lot of individuals have said, I'd rather, if I had to pick between Narcan or injectable, I'd rather injectable. And then you can titrate up. But, we spoke about this recently that in the moment, when someone is overdosing, it's very stressful, and having to fill the vial of Narcan into the needle is a very tedious process. So, ways to overcome this, we were talking about how like, the need for almost pre-filled injectable Narcan as one way, um, but also looking at ways to not Narcan someone too soon has definitely been a conversation. And what I've seen while doing outreach, actually the past week, is that few centers are now having staff carry oximeters. So portable meters that read the heart rate and also the blood oxygen level. So that way you can monitor the heart rate and oxygen levels in the blood before Narcaning. But that's at least here, that's very novel. So there is no guidelines as to what level the oxygen should be or what level the heart rate should be at before Narcaning. So I haven't seen any official guidelines come out, but that is one thing that I've seen pop up during frontline outreach.
That's really good to hear about. One of the questions in the Q&A here is, when do you recommend that Narcan be implemented in the treatment process when breathing stops? And I think there's a document that came out from a group in Philadelphia that might have some. I'll try and look for that while we're talking. And if I can't do that, then I'll add it to our resource list when we post everything.
Yeah.
Do you know what I'm talking about? That
Yeah, I can't recall. Anyway, my brain is a bit mush today, but one thing on this question though, and I know this isn't I'm sorry, Emily, this isn't probably the answer you're looking for, but like as a researcher, I would say like, well, these should be guidelines that are developed from community, right? And so, we have this idea, problem has been identified through the research. Uh, and elsewhere, this I'm not the first person to talk about this by any means, but around recommendations and developing like updated guidelines, like that's something that's really needs to be developed from the ground up. And I should say that this project that I was working on, we didn't have any funding. Like I funded it out of my pocket, really small scale study. But I think, it's a conversation starter. And I think that, yeah, you ask, these are the questions that policymakers, that people who are running programs will want to know. Okay, well, what do we need to do then? Like, give us the specific policy. And, I don't have that, but I think, that's something that a lot of folks on this call could probably participate in developing, particularly people who have that frontline and lived experience.
for
So that's
sure.
what I would say.
That's a great answer. Thank you. And I'm just looking through the chat here, and there are some folks who are talking about what happens in their organizations around like looking at the breathing rate and what are the go-tos. Thanks. So I posted an article in the chat as well about the biggest barrier is the need for a medical directive and a prescriber willing to do that. And I do know that was a situation that some CTSs or some supervised consumption services I worked with were struggling to get that directive. So absolutely. And thanks, Anjay, for putting another article in the chat about pleasure and how that factors into harm reduction. I'm also thinking about, now I'm getting distracted by the chat. Lots of good comments and lots of action happening there. I think it is interesting to consider how to come about some guidelines to support people, and then how to then talk to people who are coming in to you, or who you might interact with, who may want somebody around to help support them or to monitor them if they're using, just in case of a toxicity. I'm wondering about like there's an ethical component here too, right? Around if somebody is unconscious, do they have an understanding about how people are going to respond? It's one thing if they're in a space where overdose response is actively discussed as a possible situation, which immediately requires acknowledging that people use drugs, and so many places and spaces don't allow for that open discussion around, like people use drugs and what people will do, or what they can expect, or even asking people, how would you like us to respond should we see you not doing well? So yeah, thoughts on that, the ethical pieces there, respecting autonomy, honest conversations.
Yeah, I mean, I think the consent piece is really key, right? But and part of this is, I think, our relationship building. Obviously, you can't get consent from someone who's unconscious, but if this is also kind of speaks to the strengths of having supervised consumption sites where people have relationships and they know how people respond to any sort of intervention, right? And that those are where those conversations can happen. So, I don't think it's not gonna change like Joe Blow walking down the street who encounters someone who he doesn't know and, pulls out a nasal naloxone. I don't think that's gonna change. But yeah, I think like again, this kind of comes for me anyway, it comes back to thinking about who are direct service providers, who's on the streets, like who's responding, and like, these also kind of point to the need and the necessity for having relationships with people who we're encountering, right? It's not simply just, another client, for example, right?
Absolutely. Um, and also thinking about having an understanding of what substances people are using and what impact that might have on them. So there's a couple of questions in the chat here that both get at what are some recommendations about how people can respond in a positive or in a less dramatic, more supportive, more person-centered way. For example, if somebody like how do you do that more gentle approach of supporting people while they're recovering, especially in situations when there are limited options for respiratory support. And what do you do when there's somebody who's out on the street? And how can first responders who may not have a lot of time, and naloxone can be the quick and easy go-to. I think you said that, Jenny. Yeah, thoughts about this, thoughts or recommendations on how to approach providing support when the circumstances to do so are not ideal.
If Lucas or Jenny, do you want to say anything on that?
I can speak briefly on it. I think taking it back a step, it's kind of that's under the assumption, like the question about that someone has someone there to support them in the event of an overdose. And I'm just going off of what I've heard from participants, and also it's an unpublished study from earlier this year. And one of the questions was, who was there to support you during and after an overdose? And the most popular answer was no one. Um, so, which is heartbreaking. So, I think going back a step, it's I don't have an answer to your question, but I think it's just important to acknowledge that when we're talking about ethics of responding to someone who may be overdosing, that a lot of individuals don't have someone there with them.
Yeah, that's an incredibly important point. And it also makes me think about some of the, like, especially in rural and remote spaces, one of the things, or if people are living or staying in spaces where they can't ask for someone to watch them or plan out a response, one of the things we often promote are the virtual spotting services, which are fantastic and they do such a great job. And their ability to respond is limited by, whatever services are locally available. And I'm certain that there's some paramedics who are able to respond in a way that works really well for folks. But for others, especially in our current healthcare context where, there's wait lists for everything, wait times for even ambulance can be long. And so there's these competing priorities or for responders.
Yeah.
Want to speak to that, Jeff?
And Rebecca, we talked about this, I think, yesterday or the day before, or like, because there's a quote in from the study where someone says, for talking about paramedics, first responders don't want to like breathe in someone's mouth, like they just want to like, or and wait. I think it says something like, and wait there until he turns pink. And so part of this are actually like, it's not that paramedics or first responders are evil individuals, but the systems that they're working in, especially like here and also many other places in Ontario that are just having like skyrocketing paramedic calls. And so part of this I think like is because the system is already set up to fail communities, all communities, right? And so it's actually becomes a question about time and efficiency rather than care, right? Because to provide someone naloxone and, ensure that they have survived and, maybe they don't want to go to hospital, like, okay, that's way faster than, uh, hooking someone up to the oxygen tank, ensuring they're okay, they have a place to go, they're okay to get to the next place they need to be, right? These things take more time. And so, yeah, I think like the strains on the healthcare system and especially on our paramedics are like quite great. And so, finding ways to be more efficient is going to happen, whether that's ethical or not. So I think those are, again, something that we're not going to solve just by saying, oh, well, you just need to spend more time with people because there isn't that time.
Right.
So,
And there's someone commenting or asking a question in the Q&A here saying, responding to overdose is difficult. And with the increasing drug toxicity and other factors that play into overdose response, are we beginning to ask too much of first responders with regards to assessment and treatment? And, I think what you were just talking about there, does address that question. And that there really isn't a right or wrong answer for this. I again, when we look at what are the different components or pieces, but when we look at the context, what's happening in that context, and how is that shaping the possibilities for first responders, and the moral distress that can come with trying to respond and knowing you can't respond in the ideal way, but you can get someone so that they're breathing, and and possibly conscious. Very complicated. There are quite a few questions also asking more about titration of naloxone, and being able to do that in street settings or shelter settings, and also hearing about IM versus nasal naloxone in terms of the impacts of coming to. Jenny or Lucas, would you like to answer that? I'm thinking about you, Jenny. Maybe you can talk about your experience with supporting people with titrating IM naloxone, intramuscular naloxone.
Sure. So I just want to preface this by saying I'm not a medical professional. So this is just from my personal experience. Honestly, usually I do it based on like I'll start off with either half dose or start with one dose based on skin color and if there's any breathing at all, and then go up from there. And then in terms of the difference between intramuscular versus nasal, so nasal is a higher dose, so that is why it tends to kick people into withdrawal more heavily than I am. Like I've been Narcan before and woken up and still high, nothing wrong from intramuscular, and then I've been nasal Narcan and just in the worst withdrawal of my life. So those are the main differences.
Yeah, and I'm thinking a lot about how when people aren't used to seeing people experiencing heavy sedation as well, and so giving somebody multiple doses of naloxone and what that does to people. There was another question.
Yeah, it's kind of like people have just a knee-jerk reaction to using naloxone and they don't stop and check, is this person breathing at all? What is the color of their skin? They just automatically, people will, especially just out in the community, people will see somebody on the nod and they'll immediately call 911 or Narcan them. And so if we had more education around what an overdose actually looks like compared to a nod, that might help reduce those knee-jerk reactions.
Yeah. And those knee-jerk reactions are often based in care, right? Like wanting to be supportive, but actually potentially putting people in a situation of being unsafe or having a bad experience, right? Like I think that's an important piece too.
yeah. Yeah, and one thing I can't, I'm trying to keep up with the chat. It's almost impossible, but Dylan Griffith wrote a message that I think like even for folks that are thinking about like what does this look like in my practice or if I'm on the front lines, like just about, working at an OPS at a shelter and rarely using naloxone and, what response and monitoring looks like for in some organizations. And so, I think like seeing that is like, yeah, I mean, people know this can be practiced in very ways that aren't onerous on systems, right? And I think, yeah, like there's other discussion points around like, oh, we can't get oxygen. We need to have, a directive from an MD, et cetera. So I understand those are obviously issues, but there's again other ways to provide more care for individuals that's not going to throw them in extreme withdrawal and might not actually want to interact with you ever again, right?
Mhm. Just respectful too of some of the people in the chat talking about some of the reasons why they feel inclined to administer naloxone and not being connected to what's going on in with the heart. I'm going to read Emily's message here. That it's important to consider SpO2 and cardiac rhythm are fundamentally different physiological parameters, and a normal oxygen saturation provides no reassurance about the electrical stability of the heart. And many overdoses we are seeing here in Sudbury are impacting the electrical activity of the heart and subsequently resulting in death, despite a normal oxygen. This is why, as a nurse, I'm inclined to want to give naloxone to prevent this consequence as opposed to just utilizing oxygen. And like that makes a lot of sense. And for me, like it brings it back to the drug supply. And also, Geoff, your point around pleasure. And if people are looking for a particular effect from the drugs that they take, and if they know what's in the drug that they're taking and they know it's going to give them the effect that they want to take, and we know what's in there, we know what the risks are. But, with the unregulated drug supply, that becomes increasingly complicated. I also think about safer supply in these situations as well, where the idea was we would give people access to a drug of known quality, and that would help prevent some of the harms related to drug use, and people could use more in a more stabilized way. But our options of what medications we had to offer people were not great. They weren't what people were actually looking for in a lot of cases. And so, it's only going to be so successful if we don't have the right types of drugs, or drugs that, and not just the type of drug, but also able to consume it in the way that you're looking for. So again, if we start with the question of how do we think about what messaging and how we support people, if we prioritize or go through the lens of pleasure, then that could, result in some different ways of thinking about these things. Yeah, we just have a few minutes left. For those on the call, if you are able to join us tomorrow at our drop-in meeting, we'd love to have you. We're going to be continuing this conversation. But I just want to give Lucas and Jenny and Geoff an opportunity. Like, if you had one key message around this topic that you'd like people to think about, one thing you want someone to take away from this webinar today, what would that be? Is there a concrete policy or practice change that you'd like to recommend? Or who wants to start?
Maybe while you two think about this, maybe I'll go first. I mean, I think like on a policy level, I get this question a lot for everything. So like, I think like I'm trying to think a really small scale. So advocate for oxygen tank availability where you work, right? And so like that's, I think, a reasonable request. Is it going to solve everything? No. But I think that's like one place to start, because then that becomes more normalized as a practice, right? And yeah, so that's the start. And then something that's not drug policy related. Well, I guess it's drug policy related, but a key takeaway is that like we just need to always remember that drugs are pleasurable. Like there are pleasures in drugs. So like, let's focus on pleasure maximization, right? A rethink of the whole like harm reduction approach. And I'm not going to go on a whole rant here, but I'm kind of like the wording of harm reduction makes me uncomfortable because it does, erase these other aspects that are positive, right? So I think a rethink of the terminology we're using is useful, and we always want to be reflective and critical of the work that we're doing. Anyway, that's way too much. You asked for like one word, but those are my thoughts.
Thank you very much. Lucas, do you have any thoughts you'd like to share? No pressure.
I would say it's just important to always be learning in this field and reading the literature and trying to stay up to date and just always rethinking and do our best to help people as best as we can.
Yeah, I like that. I think for me, it's the learning and the unlearning, right? We hear about that a lot as well. Like there's so many things we've been taught about how to think about people who use drugs or about drugs themselves. Yeah, thanks so much. Thanks, Lucas. Jenny.
Isn't really policy related, but kind of just building on Geoff's point, just acknowledging that, as a society, that pleasure is a part of life. Without it, people would be miserable. You need pleasure in your life to, enjoy life, be happy. Everyone deserves pleasure. We don't get to choose who gets to enjoy pleasure. Excuse me. And who gets to determine what pleasurable actions are acceptable, what isn't. So again, just going back to what I was saying earlier, how come alcohol is fine or smoking pot is fine? So just keeping in mind that pleasure is just a regular part of life.
Yeah, very much so. And I think about those of us who are able to explore pleasure in our own homes, with people around us that support us, that is a real privilege, or without risking incarceration or things like that. Yeah, losing your child, things like that. Yeah. Anjay and Tanya, do you have the last word quickly?
I think Jenny's closing remarks were pretty on point, but yeah, great presentations. Happy to be here. Thanks all.
Yes, thank you, everyone. I've learned a few things today, and on board with a lot of what was said. So thank you. Looking at it from a different perspective, which I think I've lived myself, but it's not been put this way in a long time for me. So thank you.
Thanks, Tanya. Thanks, Anjay. There's a lot of questions that we didn't get to, and obviously that means that there's a lot more to talk about. So maybe we'll have to bring this group back together another time and go a little further with it, and actually record your presentation, Geoff. But also I will invite you again to come to our drop-in meeting tomorrow if you're available. It's at noon Eastern time, so that's Ontario time, noon. I think that's 9 a.m. BC time, so early for your BC folks. But if you are able to join us, we'll keep this conversation going and have a look at the questions that we've got here and see if we can have some good discussion on that. With that, let me wish you all a good rest of your day. Big thanks to Geoff, to Lucas, and Jenny for being here today and sharing this with us. And big thanks also to Tanya and Anjay for supporting the webinar. And thanks to all of you for making times in your days to come to this as well. Thanks so much. Bye, everyone.
Thanks, everyone.